Hello, I'm Alex Dekovich. I'm a senior faculty member at the University of Texas MD Anderson Cancer Center in Houston, Texas. I'm here to discuss my paper, which will be appearing in GI endoscopy, titled Transnasal PEG placement in patients with head and neck cancers. I see many patients with head and neck cancers that require enteral access, either during their time of chemoradiation or during their time of surgery. And on occasion, we encounter patients that have conditions which preclude the standard approach to PEG placement, i.e., the standard approach being through the oral cavity. Things that we found to be difficult are patients who have oral tongue cancers, which are large, taking up the oral cavity, not giving us an access site, patients with trismus in particular, who have all their teeth intact, and we're not able to find a way through the toothy structures. Also, we've had difficulties with patients with hypopharyngeal tumors, not being able to find an adequate pathway to the standard approach to PEG placement. And therefore, we have known from past reports that an approach through the nose is a possibility. And therefore, we proceeded to develop a series of patients in which we proceeded to place the PEG tube transnasally. Although various and sundry endoscopes have been used in the past, but in every case it's been the smallest available diameter scope. And the one that we chose was the Olympus ultra slim 4.9 millimeter endoscope. We use a standard approach through the nose. We generally ask the patient prior to the procedure which side of the nose they breathe through better, and we generally go for that side. Once we have established that, we have anesthesia help to sedate these patients. The majority of our patients did not need endotracheal intubation, but on certain occasions, because of the anesthesia's concern over the airway, these patients were intubated. They all received propofol sedation. With this regimen, we were successful in all the patients that we attempted. As far as the choice of the kit, we used the Boston Scientific kit, and we chose to use the push method as opposed to the pull method. My reasoning for that was that in the pull method, the dilator portion is rather stiff and long, and also because of the attachments necessary, there is a knot created, and I felt that this perhaps would be more traumatic to the nasal mucosa and to the hypopharynx than the push method, which has a long, smooth, slippery plastic sheath that I felt was a better match for this particular approach to PEG placement. And indeed, it seemed to bear fruit in that regard. We were, as I mentioned, quite successful in this. Allowed us to place these feeding tubes in patients that ordinarily would not have been candidates for our approach. And also in a lot of these situations, because of the sedation and the intubation necessary, the interventional radiologists would shy away from this and therefore have these patients fall in our laps, so to speak, and with the natural reluctance on the part of surgeons to go in and do an open procedure. So we ended up being able to give these patients a good caliber tube and avoiding the usual complications of open procedures. The other aspect of this is that our complication rates were very low, and most of them were minor in nature. None of the patients had any nasal trauma at all. So one of the things that we do as a preliminary is that we spray the nose both sides with Afrin nasal spray to shrink the mucous membranes, and we also anesthetize the nose with topical lidocaine. We feel that this is helpful, and we would recommend it as a standard of care. Thank you very much for your attention, and thank you for reading the article. We appreciate it.